Imagine experiencing like excruciating pain during intimacy, right? And you're told by just a parade of specialists that your organs are perfectly healthy.
Yeah, your lab cultures are negative, your MRI is totally clean.
Exactly. And they ultimately just tell you, well, you probably just need to relax.
Right, which is just, I mean, it's a uniquely isolating experience when the clinical imaging completely fails to validate this localized, really debilitating agony that a patient is feeling.
It totally makes people question their own reality.
Oh, absolutely.
Well, welcome to today's deep dive. We are tackling a highly specific medical mystery that, haunts a lot of patients, yet it rarely gets a definitive answer in a standard 15-minute consult.
Yeah, those short appointments just aren't enough for this.
Right. So we are exploring a physiological chain reaction here. Specifically, can hypertonicity, basically severe tightness of the piriformis muscle, actually contribute to the deep sciatic and pelvic nerve irritation that triggers deep thrusting pain during intimacy?
And the short answer is a resounding yes. But to understand the long answer, we have to look entirely past the surface symptoms.
Like the gynecological or urological stuff.
Exactly. We have to dig into the actual mechanical wiring of the lumbopelvic region.
And to map that out for you, the listener, we're pulling from a pretty massive, diverse stack of sources today. We've got data from stat pearls. We're integrating clinical guidelines on genitourinary syndrome of menopause, or GSM.
Which is a really crucial piece of the puzzle.
Yeah, definitely. Plus, we're dissecting anatomical studies of the sacral plexus and looking at specialized physical therapy protocols from pelvic rehab centers.
The goal really is to synthesize all of this so you have the full biomechanical picture. Because, honestly, chronic pelvic pain and sexual dysfunction are just notoriously misdiagnosed.
They really are.
And understanding the mechanical architecture of your pelvis, well, it empowers you to advocate for the exact diagnostic tests you actually need.
Right. It gives you the vocabulary to bypass years of those ineffective organ-centric treatments. So let's start by establishing the geography of this problem.
Good place to start.
Specifically, let's talk about the piriformis muscle. It sits deep in the gluteal region, and it acts primarily as a lateral rotator of the hip, right?
Yeah, but it also exerts this direct pressure and rotational force right on the sacroiliac joint.
Right. And where exactly is it spanning?
So it spans from the anterior surface of the sacrum straight across to the greater trochanter of the femur. And because of that very specific diagonal placement, it crosses directly over the sacral plexus.
Which is basically the nerve hoe.
Exactly. It sits intimately against the S2 and S3 spinal nerve roots, and those supply the pelvic inner organs, the gluteal region, and, the lower extremities.
Okay, so we also have to factor in the sciatic nerve here, which is like the thickest nerve in the body.
Yeah, it's massive.
So if the sacral plexus is sort of the main fiber optic junction box for the lower body's nervous system, and the piriformis is sitting directly on top of it, we can't really think of it as a protective blanket, can we? Like, if this muscle becomes hypertonic and locks into a chronic spasm, is it acting more like a rigid ratchet strap being cranked down over those delicate cables?
A tightened ratchet strap is actually the perfect visualization for this.
Really?
Yeah, because when the piriformis becomes hypertonic, it stops being this pliable, flexible tissue. It becomes super rigid.
Wow.
And it effectively pins the sacral plexus and the sciatic nerve right against the bony pelvic brim.
Ouch.
Yeah, it's bad. This mechanical crushing compresses the vasa nervorum, which are the tiny blood vessels that actually supply blood to the nerves themselves.
Wait, nerves have their own blood vessels?
They do, yeah. And when those get crushed, it causes nerve ischemia, so a lack of oxygenated blood flow. And that triggers immediate, really intense neuropathic pain.
And according to our anatomical sources, the sciatic nerve is actually particularly vulnerable here because of this wild genetic variation.
Oh, yeah, this is fascinating.
Right, so in about 85% of people, the entire sciatic nerve passes below the piriformis muscle. But in about 10% of the population, it actually splits before it even reaches the muscle.
Right. So the tibial portion of the nerve passes beneath the piriformis, just like normal. But the common peroneal portion literally pierces directly through the belly of the muscle fiber.
Through the muscle itself. So for like 1 in 10 people, a major nerve is threaded right through the middle of a muscle that is incredibly prone to spasm.
Exactly.
Mechanically, that seems like a massive vulnerability. Like every time that muscle contracts to rotate the hip, it's just subjecting the nerve to intense shearing forces.
It's a huge anatomical bottleneck. I mean, if you're in that 10% and your piriformis goes into spasm, the muscle fibers are just strangling that nerve from 360 degrees.
That sounds agonizing.
It is. But even for the 85% whose nerve just passes underneath, that ratchet strap effect against the bone, that's more than enough to cause severe radiculopathy.
Okay, so we've established the crushing mechanism in the gluteal region. But to answer our core mission today about deep thrusting pain, we really have to trace this tension to another specific nerve in this neighborhood, right?
Yes, the pudendal nerve.
Right, our sources spend a ton of time detailing the highly complex path of this specific nerve.
And for good reason. So the pudendal nerve originates from those same S2 to S4 nerve roots. It descends beneath the piriformis muscle, meaning it's directly subjected to that same ratchet strap compression we just talked about.
Okay.
But then it takes this bizarre anatomical detour. It exits the pelvis completely through the greater sciatic foramen.
It actually leaves the pelvis.
Yeah, it fully exits, crosses over the sacrospinous ligament, and then immediately dives back into the pelvis through the lesser sciatic foramen.
It's like it leaves the house just to walk around the porch and come back in through a different door.
That's exactly what it does. And once it re-enters the pelvis, it travels through Alcock's canal, which is this very narrow sheath formed by the obturator internus muscle fascia.
So it's navigating through all these tiny pinch points.
Tons of them. But its sensory coverage is what makes its entrapment so devastating. The pudendal nerve provides sensation to the vulva, the clitoris, the penis, the scrotum, the perineum, and the anal and urinary sphincters.
Wow, so basically everything down there.
Yeah, it dictates primary genital sensation and pelvic floor autonomic function.
Wait, so mechanically that's a massive leap.
Yeah.
If the piriformis is locked up back in the glutes, how on earth is that triggering a severe burning pain localized all the way in the front, in the genitals?
Okay, so that comes down to the physiology of referred neuropathic pain and ectopic firing.
Okay, break that down for us.
Think of stepping on a garden hose, right? The water stops flowing at the nozzle, but the actual blockage is like 50 feet away at the spigot.
Oh, I see.
Yeah, so when the pudendal nerve is compressed at its root, which is a type I entrapment right beneath the piriformis, the nerve becomes highly irritable. The myelin sheath degrades, and the nerve just starts firing abnormal action potentials.
So it's basically sending misfiring signals.
Exactly. These distress signals travel up to the dorsal horn of the spinal cord. The brain receives this barrage of pain signals, but because the pudendal nerve's primary endpoints are in the genitals and perineum, the brain spatializes the pain there.
Oh, wow.
Right. The brain gets a 911 call and maps it to the genitals, even though the actual mechanical trauma is happening deep in the buttocks.
So that connects directly to our focus on deep thrusting pain, because the sources frequently group this piriform tension with general hypertonicity of the entire pelvic floor and that obturator internus muscle you mentioned.
Yeah, they're all sort of co-contracting and just refusing to release.
Which creates a relentless vice grip on the pudendal nerve, right?
Yeah.
Resulting in pudendal neuralgia.
Yes. And that constant compression creates a state of peripheral sensitization. Basically, the pain threshold drops dramatically, so a stimulus that normally wouldn't cause pain at all is suddenly perceived as agonizing.
Which perfectly explains the severe sexual dysfunction detailed in our sources. For women, they note this manifests as deep dyspareunia, so severe pain in the pelvis during penetrative sex.
Right.
It can trigger vaginismus, which are these involuntary protective muscle spasms, and even in rare cases, PGAD, which is persistent genital arousal disorder.
Yeah, and PGAD is a really prime example of the nerve losing its inhibitory signals due to that compression, which results in this chaotic, unwanted afferent firing.
And this pathology applies equally to men, too, right?
Oh, absolutely. The sources note that pudendal neuralgia in men can present as painful ejaculation, erectile difficulties, and this really paradoxical decrease in genital sensitivity that is somehow mixed with agonizing pain.
Wow. So synthesizing all of this, when a patient experiences deep thrusting pain, the organs themselves might be functionally flawless.
Often they are.
It's just a physical impingement causing an electrical misfire. Every time there's a deep thrust during intimacy, it's adding intense sheer force and stretching to a nerve that's already trapped in a muscular vice grip.
You nailed it. The hypertonicity in the pelvic floor acts as this hyperalgesic amplifier. It takes normal mechanical friction or pressure, and because the pudendal nerve is crushed and highly sensitized, it converts that normal input into localized stabbing nerve trauma.
Okay, so if the mechanics are this straightforward, and we can trace the symptoms directly back to this muscular entrapment, why do patients suffer for literally years without an accurate diagnosis?
Well, it is the ultimate diagnostic blind spot. Because the symptoms present acutely in the genitals, the bladder, and the rectum, patients naturally seek out gynecologists, urologists, or
Right,
gastroenterologists.
you go to the doctor that matches the body part that hurts.
Exactly. The clinical presentation perfectly mimics organ-based diseases. So pudendal neuralgia is constantly misdiagnosed as chronic pelvic pain syndrome, endometriosis, prostatitis, or interstitial cystitis.
And patients end up taking endless rounds of antibiotics for recurrent UTIs that never actually culture any bacteria.
Yep. Or they undergo invasive laparoscopies to look for endometrial lesions that just aren't there. And, standard medical imaging actually provides false comfort here.
How so?
Well, a patient will get a routine pelvic MRI, and the doctor will look at it and tell them everything is completely normal.
Because a standard MRI is calibrated to look for gross structural abnormalities, right? Like tumors, cysts, large muscular tears. It doesn't have the spatial resolution to visualize a hypertonic muscle just clamping down on a microscopic nerve fiber.
Precisely. Furthermore, there's a major differential diagnosis that frequently clouds the clinical picture, particularly for women in perimenopause and postmenopause. And that's genitourinary syndrome of menopause, or GSM.
The sources do spend a lot of time on GSM. As estrogen levels drop, the mucosal tissues of the vulva and vagina atrophy. They lose their elasticity, causing severe vaginal dryness, burning, and dyspareunia.
Right. So given the symptom overlap, a doctor hearing a patient in her 50s complain of painful sex is immediately going to assume an estrogen deficit.
Which is a highly logical clinical assumption.
It really is. But the way to differentiate between the two lies in the treatment response and the mechanical triggers. So GSM is a tissue-level issue that responds exceptionally well to local vaginal estrogens, things like Vagifem, estriol, or estring.
Because those treatments restore the mucosal thickness and blood flow.
Right. But if a patient undergoes localized estrogen therapy and the superficial dryness resolves, yet they still experience that sharp, stabbing pain, specifically with deep thrusting.
Then the estrogen isn't failing, it's just treating a plumbing issue when the house actually has an electrical short circuit hiding behind the drywall.
That is a great way to put it. Another definitive hallmark is how the pain responds to biomechanical load. The sources explicitly note that nerve entrapment pain is heavily exacerbated by prolonged sitting.
Oh, because sitting compresses the sacrotuberous ligament and forces that hypertonic piriformis to further crush the pudendal nerve.
Exactly. Hormonal tissue atrophy, on the other hand, does not exponentially worsen just because you sat in an office chair for 3 hours.
That makes total sense. And that distinction really highlights why doctors must take a detailed musculoskeletal history. Asking a patient if they are an avid cyclist or a heavy lifter, or if they just sit for 10 hours a day, that points directly away from endocrinology and straight toward biomechanics.
It really shifts the entire diagnostic paradigm.
So let's cross over into the solution space. If standard MRIs are essentially useless for this, how do modern neuropelvic specialists actually prove this entrapment exists?
So they utilize advanced imaging protocols, things like magnetic resonance neurography, MRN, and diffusion tensor imaging, or DTI.
Okay.
These scans are entirely different from standard MRIs. DTI specifically actually tracks the diffusion of water molecules along the nerve axons.
Wait, so they can mathematically visualize the actual flow of fluid inside the nerve bundle?
Precisely. It calculates something called fractional anisotropy. If the pudendal or sciatic nerve is compressed, the scan can physically show the exact point where the nerve thickens and swells from the entrapment.
Wow, so you can literally see the structural lesion caused by the piriformis.
You can, but beyond the imaging, the clinical literature points to an interventional gold standard for diagnosis, and that's the image-guided diagnostic nerve block.
How does that work?
A specialist will use a CT scan or ultrasound to guide a needle with pinpoint accuracy right into the belly of the piriformis muscle, or directly into Alcock's canal. Then they bathe the nerve in a local anesthetic, like bupivacaine.
And if the pain goes away?
Exactly. If the patient's chronic, debilitating pelvic pain completely vanishes for a window of a few hours, the diagnosis is confirmed. You've found the exact site of the entrapment.
That's incredible. So once that entrapment is confirmed, what is the protocol for releasing that vice grip? Because our physical therapy sources are pretty adamant that doing standard Kegels is actually detrimental here.
Oh, absolutely. Performing Kegels on a hypertonic pelvic floor is like trying to tighten a knot that you are desperately trying to untie. It just further shortens the muscle fibers.
That sounds like a bad idea.
Yeah, so pelvic floor physical therapy for pudendal neuralgia focuses instead on myofascial release, deep tissue mobilization to dissolve trigger points, and really correcting that lumbopelvic hip biomechanics.
So the physical therapist is manually working to restore the normal resting length of the sarcomeres within the muscle.
Right, and by lengthening those muscle fibers, they release the mechanical tourniquet. That allows normal blood flow to return to the ischemic nerve. They're structurally changing the environment around the sacral plexus.
Okay, but what about cases where the hypertonicity is chronic? Like where the ratchet strap has been locked down for years and just refuses to yield to standard physical therapy?
Yeah, in those cases, the sources detail a really fascinating medical escalation, the use of botulinum toxin, Botox.
Botox. I mean, we usually associate Botox with cosmetic procedures.
We do, but its mechanism of action is incredibly effective for severe muscle spasticity. A physician will inject Botox directly into the hypertonic piriformis and obturator internus muscles.
Okay, but how exactly does that force the muscle to let go of the nerve?
So the botulinum toxin enters the neuromuscular junction, right? And it cleaves specific proteins called snare proteins.
Okay.
And this entirely prevents the release of acetylcholine, which is the neurotransmitter responsible for telling the muscle to contract in the first place. So it essentially causes a targeted chemical denervation.
Meaning the muscle is chemically paralyzed.
Exactly, for roughly 3 to 4 months. And because the muscle can no longer contract, it enters a state of temporary atrophy. It shrinks.
Ah, I see.
Yeah, this physical reduction in muscle mass drastically decompresses the greater sciatic foramen. It gives the pudendal and sciatic nerves the physical space they desperately need to heal and desensitize.
But wait, if a doctor injects a neurotoxin into a primary hip rotator to induce temporary atrophy, how are you not just dragging your leg when you walk?
Yeah.
It seems like paralyzing a gluteal muscle would destroy your gait.
It's a highly logical concern, for sure. But the biomechanical redundancy of the human body is just astounding. The loss of piriformis function actually does not induce clinically significant gait deficits.
Really?
The surrounding musculature, specifically the massive gluteus maximus and gluteus medius, they rapidly adapt. They simply take over the mechanical load of lateral rotation and pelvic stabilization while the piriformis is effectively offline.
That's wild. The larger muscles just absorb the structural responsibilities. And that buys the nervous system a massive 3-month window to clear out the inflammation and reset its pain thresholds.
Exactly. It breaks that awful cycle of chronic peripheral sensitization.
Pulling all of this together for you, deep thrusting pain, severe pelvic burning, or unexplained sciatic symptoms are not just in your head, and they are not strictly limited to organ pathology.
Not at all.
As we've seen through the anatomy, it can be a deeply mechanical crushing of the sacral plexus and pudendal nerve by a hypertonic piriformis muscle.
Right. So if you are navigating mysterious pelvic pain that notably worsens with prolonged sitting or is triggered by deep thrusting, you can bring this specific terminology to your physician.
Give them the exact words.
Yes. Mention pudendal neuralgia. Ask about piriformis syndrome. Requesting an evaluation for musculoskeletal nerve entrapment rather than just looking at hormonal or infectious causes that can entirely alter the trajectory of your medical care.
Now, before we wrap up, there is one final, incredibly provocative thought embedded in our sources that, honestly, completely flips the script on everything we've just discussed.
Oh, this is my favorite part.
Right. Because we have spent this entire deep dive analyzing the piriformis as the primary aggressor. We called it a ratchet strap, a vice grip, and detailed how to chemically paralyze it.
We basically treated the hypertonic muscle as the root pathology.
Exactly. But what if the piriformis is just an innocent bystander desperately trying to do its job in a failing system? One of the anatomical sources notes that damaged, stretched, or even congenitally lax pelvic ligaments, specifically the sacrotuberous and sacrospinous ligaments, can cause the sacrum bone itself to become highly unstable and rotate out of alignment.
And those ligaments are the primary structural anchors of the pelvis. So if they are loose, the entire skeletal foundation is compromised.
Exactly. If your skeletal frame is slipping out of place, your piriformis muscle might be violently spasming on purpose.
Right.
It might be working absolute overtime, locking down in a desperate physiological attempt to hold your pelvis together and keep your spine stabilized against your femurs.
It really recontextualizes the hypertonicity entirely. I mean, the tight muscle isn't the root of the evil. It's a frantic secondary compensation mechanism for underlying skeletal instability.
It fundamentally changes how you view the chain reaction of pain within the body. And it's just something for you to deeply consider as you navigate the miraculous and often highly frustrating mechanics of human anatomy. Sometimes, to find the true source of the pain, you have to look past the organs, look past the nerves, and question the structural integrity of the frame itself. Thanks for joining us on this deep dive.